discussion of what Ankur has already presented. Now, why we are concerned with growth restriction, because it is observed in 1/4 of the newborns and approximately 30 million infants suffer from IGR every year. And the burden of IGR is concentrated mainly in Asia, which accounts for 3/4 of all affected infants, and is a second leading contributor of perinatal mortality, contributes 40% of the stillbirth, and there is increased risk of perinatal morbidity, which involves neurodevelopmental outcome, additional cardiovascular disease and metabolic syndromes. So these are all few of the major concerns. There are many more, but these are all the highlighted major concerns. And to begin with, fetal growth restriction is not something that just ends by the delivery. If there is fetal growth restriction in utero, that actually affects the entire programming which happens in utero for the adult life. And that is called Barker's hypothesis. Barker's hypothesis. So whatever we are now is planned in utero. And the major reasons why in India there are so many diabetes and all, because there is so many cases of growth restrictions which are not managed properly, and whatever impact you have in utero will have long-term consequences, medium or long-term consequences, which will be manifested in the adulthood. Okay. So it is very important, once there is growth restriction, we understand that since the programming is going on, so when do we want to deliver? Are we delivering it too early? Can we wait for some more time in utero with all safety nets? So all those things we need to answer. Now there is 5D in fetal growth restriction. Number 1 is detection. That is the first thing. We need to identify amongst the cohort which is growth restricted. Number 2, once we detect them, then we have to classify whether it is early or late onset FGR. And then after classification, we need to stage them, which is basically a functional method of staging, which is by doing a cardiovascular risk profile in the form of Doppler. Then, depending on the stage, we determine when do we need to deliver it. So what should be the delivery threshold for this particular case after staging it. And 5th is, if there is a monitoring failure or non-compliance from the patient side, like suppose we have seen it is a stage 3 FGR, we need to monitor, we need to scan her or do Doppler every twice weekly or thrice weekly, and they don't come to you, they come after 2 weeks or 3 weeks, and then there is intrauterine demise. So these are all because of the monitoring failure. So these 5 Ds we need to address in our presentation. Now, when we talk about FGR, there are a lot of causes which may contribute to FGR. I will not go through them. Ankur has already preluded to this in the last talk. Now, important thing to understand is, when we look at the FGR group, they may be small for gestational age, or even they may be appropriate for gestational age. So you don't be in a misconception like if it is appropriate for gestational age, they can't be FGR. So FGR includes small for gestational age as well as for appropriate for gestational age. Now small for gestational age, you can pick up which is true small for gestational age, which is just a physiological thing, or which is a pathological counterpart of small for gestational age, which is fetal growth restriction, by doing Dopplers and effective fetal weight. If there is Doppler abnormalities or effective fetal weight less than 3rd centile, you know these are the pathological ones, and they need to be monitored more carefully and more closely. In appropriate for gestational age, again, Doppler gives you a clue and growth velocity. So this growth velocity concept is very important. Like, suppose I have scanned today and growth is falling within the normal range. That means between 10 to 90th percentile it is showing. But next time when she is coming, still it is in that range, but it has dropped significantly. Significantly, when I when I tell significantly, it is 2 quartiles. We will discuss that. So if it has dropped, but still it is within that window period, it is appropriate for gestational age, but still it is FGR.
Yes.
So this concept should be very clear. And also majority, 70% of the term stillbirths are not SGA. They are AGAs. So we always talk about if this is SGA, this risk of stillbirths and all, but 70% of the stillbirths are not contributed by SGA, they are appropriate for gestational age. So we can never be complacent that if we are seeing, that's why every time when she comes to you for scan, after 20 weeks, you have to plot them in a graph. You have to use standardized growth charts and you have to plot them in a graph to see the trend. Because what is important is trend, knowing the trend, how baby is growing. If baby maintains at a lower trend throughout, it is not pathological, it is just a constitutional or small for gestational age. But if the baby was doing well and then it is showing a dip, then there is some problem with that. We will come to the primary definition of that. If you look into definition of small for gestational age in all this recognized society, there is more or less they are in agreement with each other with that 10th percentile cutoff. Effective fetal weight or birth weight, whatever less than 10th percentile. ISIOG just adds Doppler to it because ISIOG and FIGO, they go hand in hand. They always take Doppler into consideration, which is all about the Delphi consensus, which he has already discussed last time. Again, I will recap that. But if we go with the definition of, sorry for the spelling of definition, of FGR, in all these societies, there is some differences you will find, some differences. And there is concordance in ISIOG and FIGO. They all use this Delphi consensus. And what is this Delphi consensus? Again, I will repeat that. But if you look at the Canadian society, they'll take effective fetal weight or AC less than 10th percentile, which is almost overlapping with small for gestational age. RCOG, they take effective fetal weight or same like Canadian society they take. Again, there is some overlap here. SMFM, this is the American society basically. So in US there are 2 kinds of societies. One is the American College and then there is for fetal medicine exclusively there is SMFM. This SMFM, they don't include Dopplers. So here they take birth weight less than 10th percentile and here they take effective fetal weight less than 10th percentile. There is no mention of Dopplers in all this. So Dopplers are only included in this ISIOG and FIGO definition for fetal growth restrictions. See, the idea is not to memorize this. Idea is just to have a bird eye view that how different societies all over the world, they are defining FGR. So they have different parameters. They have different parameters. Now, one is heart and other is brain. They have to go hand in hand. Why? I will explain.
Sir, I can't understand the rationale behind the SFFM criteria, just excluding Dopplers everywhere and just putting all and birth weight and in SGA and expected fetal weight in FGR.
SMFM, they are little atypical. They even for twins also, they don't recommend for monochorionics also doing Dopplers in every visit. So they have their own school of thoughts. They even don't recommend ductus venosus also doing for that growth restriction management and all. So they have a little bit off the track, they deal with it. Okay. Now, there are 2 components when you look at FGR, or 2 different stages, but they are most of the time they are in continuum. Early onset and late onset. Now, Ankur, last time he has described that in early onset the problem is basically the management, not the diagnosis. And in late onset the problem is diagnosis, not the management. Because in late onset if we see something dropping, then we know that it is more than 32 weeks, so the easier way is to deliver it out. But the problem is diagnosis, because many times we feel ki if there's problem with that measurement of the biometry, baby is not in a good position, there is errors in measurements and all. So there is always that dilemma whether I am measuring correct or not, something like that. So diagnosis is a problem, management is never a problem. Now, if you look into the early onset, the placental disease is always severe. And that is why all this, when placenta is the end organ for all these vessels, so if placenta is very diseased, your umbilical artery will be abnormal, and they are highly associated with even preeclampsia. In late onset, the placental disease is mild. That's why even your umbilical artery may be normal, your middle cerebral artery may be also normal, but when you do a CPR, that may be abnormal. Right? So, the severe the placental disease, there will be problem with the umbilical artery. If it is very mild, because at least, like Ankur last time told, there should be 30%, the 30% dysfunction in the placenta, in the villus circulation of the placenta, for the Doppler changes to take place. So if, when I'm saying mild, it may be less than 30%, which is not affecting your umbilical artery, but still there is problem there, but it's not affecting your umbilical artery. So there is a rule of 30, 50, 70. 30% you start getting changes in the umbilical artery if there is 30% dysfunction of the placenta. If there is 50% dysfunction of the placenta, you start getting absent. And there is 70%, you start getting reversed. So the first two categories, 30 and 50%, deals with the hypoxemic state, and 70% deals with the acidemic state, when there is reversal. Okay. Now, you have to understand all this. Once you start understanding all this, then you will start translating the same concept in your imaging. Hypoxia is there obviously in this, but what happens when in early onset, less than 32 weeks, there is hypoxia. Now, you know, I have told the placenta is more damaged in early onset. Placenta is more diseased, and if your end organ is more diseased, umbilical artery drains into the placenta. So umbilical artery will start showing high resistance flow pattern. And when umbilical artery starts showing high resistance flow pattern, now heart has to push more, heart has to exert more to push more blood into the umbilical artery, because umbilical artery is now no more a low resistant vessel. It is a high resistance vessel. So heart is acting, because if umbilical artery is high resistance, that means there is increased afterload to the heart. Now heart has to pump against that resistance. So there will be more of cardiovascular compromise in the early onset, because heart is acting against a very high resistance umbilical artery. Right? And when there is problem there, heart is trying to compensate for that. What happens? There is increased pressure in the ventricles, which is transmitted to the atrium, and then that right atrial pressure, because right ventricle is the dominant ventricle in the fetal life. So the changes will take on the right, the changes will happen earlier on the right side than on the left side. So right ventricular pressure increases, which is transmitted to the right atrium, and that is transmitted to ductus venosus, and which is reflected in the form of abnormality of the A wave in ductus venosus, reversal or absent A wave in the ductus venosus. So these all are the consequence of placental dysfunction leading to systemic cardiovascular adaptation, and then there will be decompensation. But when the same insult happens later on, though there is the hypoxia to same level, at this point what happens, your placenta is not that diseased. So when placenta is not that diseased, umbilical artery will not show very high resistance flow pattern, it will behave normally. So heart is happy, because heart is not pumping against the resistance of umbilical artery. Umbilical artery is normal because placenta is not that damaged, so heart is happy. But problem happens at this stage, your brainstem becomes active. In early phase, less than 30-32 weeks, your brainstem is not mature. So brainstem does not understand what hypoxia is happening and how should I react, because brainstem is not mature. But after 30-32 weeks, brainstem starts getting matured. So brainstem now, it starts sensing hypoxia. And when brainstem starts sensing hypoxia, it starts reacting in a way of that cerebral redistribution and CPR abnormalities, and if the brainstem is more suppressed with this hypoxia, it may cause cardiovascular compromise and failure of the heart. So here the central role is the cardiovascular adaptation, and there this is a systemic cardiovascular adaptation because of the umbilical artery, and here there is a central cardiovascular adaptation because of the brainstem phenomenon, right? The same thing is reflected here. There is high tolerance to hypoxia here because there is immature brainstem, and when the brainstem starts getting matured, they have low tolerance to hypoxia because even small amount of hypoxia will trigger brainstem to act on that, right? And this category of early onset have high mortality and morbidity, though there is lower prevalence. This prevalence is almost as high as 10%, and this has 1 to 2%. So it's much lower prevalence but high mortality and morbidity. Here you have lower mortality and morbidity, but they have high prevalence and poor long-term outcome, and this is common cause of late stillbirth. So this is more dangerous, and management is more tricky in this case. This is relatively less dangerous but difficult to pick up these cases. That is why stillbirth is more common in this, because we have failed to pick up this late onset FGRs, right? Again, we will come back to this.
Sir, why high due to though high tolerance to hypoxia, why high mortality and morbidity?
Which one?
Early onset.
Early onset, the problem starts happening because since very early, like 20, 22 weeks or whatever, the heart starts pumping against the resistance of the umbilical artery. So a time will come when it will no more compensate for that, and it starts to decompensate. So that's why there is higher mortality and morbidity, in the sense that first of all, heart is failing earlier than that, and morbidity because the changes which are happening, and because of those changes, if we try to deliver it early, it will be very premature fetus.
In overall aspect, the high mortality and morbidity is
Yes.
As the management options, there are no management options.
Yes.
Very premature. Okay.
Yes. That's why we have.
Is it possible to have a DB abnormality without a severe Doppler abnormality umbilical artery?
Less likely. Then we need to check our Doppler techniques. We need to repeat because it is not possible. And also, one thing important to understand is FGR is a very heterogeneous group. As I showed you, it may have multiple causes, and that's why not all FGRs will behave in a similar manner. They will follow the steps, but some will be little fast in deteriorating, some will maintain plateau for longer period of time. So there is different way the fetus reacts. Like you are into practice of 5 years, 10 years, whatever, you see so many FGR cases, you will realize that not all FGR behave in the same manner. Some manage to be in that for lot of weeks, some immediately next week you see there is changes happening. So it is very heterogeneous. So there is the timeline is not fixed for all FGR cases. But we should understand what are the changes based on which we will raise red flag.
The disease progression as well as the vital multi-organ progression is rapid in late onset rather than early onset.
So the window period for late onset is less because the brainstem is now
mature, so reacts early.
So the threshold for hypoxia is lower in the late onset as compared to the early onset. Now, to start with, first of all, we should be very clear when are we assigning the dates, because most of the time you will see the growth restrictions has been reported, but unfortunately the dating was missed. So we have to be first clear on the dating. If it is natural conception, if it is IVF, then okay, then there is no issues provided they have used this embryo or blastocyst transfer date. So we have already discussed in our previous talk, and we have softwares which does all that. We don't need to calculate, just we need to know how many days there is a difference and we need to correct it. So we can do that. Now, this is one conceptual slide. Just be with me on this slide. There are two demands of the fetus. One is the nutritional demands, another is the respiratory demand. Right? Now, these are the like different gestational weeks, 20, 30 and 40. Initially, the fetus will have more of a nutritional demand. Okay? Exponentially it rises because fetus needs to grow. Fetus needs to grow, and for growth it needs nutrition. And once the fetus has grown and becomes matured, then the respiratory demands exponentially increases in the last phase. Because initially it does not need that much of oxygen, it is smaller, very small. The respiratory needs will be very less, but it needs more nutrition to grow. And in the later phase, as it has grown sufficiently, now it needs more oxygen because now it has to
So
have
this is
that
also
respiratory
another.
demands.
So this is also another cause of rapid disease progression in late onset FGR.
Late onset. That's what I'll just explain you. So if your insult happens at this point of time, early onset, baby will be small because it will interrupt this, but baby's oxygen demand is much less at this point of time, so baby will not. So I mean, the growth will suffer more. Baby will be growth restricted, glaringly growth restricted. Okay, but on this aspect, if late onset FGR, now what happens? Ki baby's growth will not be much changed because baby has already attained its growth. Now the problem is, that's why it is easy to miss, because when you're looking at the growth alone, it looks apparently fine. But what happens here is, since the respiratory demand is very high, if there is a problem in this respiratory issues, hypoxia, that will trigger brainstem as it is mature now, and then that causes your central cardiovascular compromise or adaptation. Okay? So the placental dysfunction has got two roles here. One is slow fetal growth or starvation, which happens earlier, and then the later on, because of hypoxemia, there is high chances of death and disability. Okay, so same placental dysfunction early on will lead to mainly starvation and growth restriction, but baby will survive. Baby will not die immediately. Baby will survive as long as there is compensation happening. But later on, if the insult happens, the same placental dysfunction is more lethal because the same hypoxemia, it triggers your brainstem and may lead to death and disability. Are you getting me?
Yes.
So this is very important aspect to understand, as placenta meets both the nutritional and the respiratory demands. Now, growth chart, Ankur has discussed last time. This is just a recap, and I will not go into detail because growth chart, if we need to discuss in detail, that is a separate presentation. Okay, there are a lot of papers on it, and then we need. But just a brief idea I will give you. This Alexander is a local growth chart, and these are all Hadlock, NICHD, Intergrowth, WHO, so on and so forth. These are all charts, and if plotted for the same parameters, you see they all are in different zones. Now, how do I say which is better, which is best, or which is worse? Now, if you see this paper, if your 10th percentile line is lower, this dotted 10th percentile line is on the higher side, and this solid 10th percentile line is lower. So these red dots are all adverse outcome. So if your 10th percentile is lower, it will pick up more of your red circles. Okay? But at the cost of your green circles. Green circles are the normal ones. So there will be a lot of false positive, but it will pick up maximum number of this diseased one, which is responsible for adverse pregnancy outcome. If your growth chart, whatever growth chart you are using, if the 10th centile is on the higher side, it will be little bit more specific, because it will not pick up like When I say more specific, that means the false positive will be less in this side, but at the same time there will be false negative. In the sense, it will miss these red dots, red circles. So this 10th percentile line will pick up more cases of adverse pregnancy outcome, but at the same time it will also raise false alarm for a lot of normal cases of this 10th percentile line. And this 10th percentile line will miss on this adverse pregnancy outcome circles at the cost of picking less number of true positive cases. So which is better? You want to be on this or you want to be on this? Whichever growth chart you are using, the 10th percentile.
So depending upon the socioeconomic status, whatever, in developing countries the upper one is the better, and in developed countries the lower one is the better.
Okay. So by and large, your 10th percentile should be on the lower side, because if it is on the lower side, you will pick up more cases of adverse pregnancy outcome. But yes, you will call more patients as growth restricted, and you will do more scans for patients. But still, that is better. That is better because you are not treating them. You are just calling them for scans, and it is a preventive measures you are doing. But you are not missing on those diseased ones which are responsible for adverse pregnancy outcome. Unlike if your threshold is high, so you want to keep your growth chart, whichever you are using, the 10th percentile on the lower side to pick up more cases, diseased cases, right? Now there are lot of charts, and amongst them the consensus is that still there is debate on a lot of things, but Hadlock or modified Hadlock, which we
So
are using,
if we take
is
the higher one, then we are, not missing the adverse cases now. Suppose for, so if we take,
if you are using the higher cutoff for 10th percentile,
then
you
we should
look-
not be missing the
you look-
adverse one.
you look at the red dots. If you are taking this line,
Then we are missing the above the red dots above the line, na? If you're taking
you are
the lower
picking,
one.
no, if you are taking this, you are diagnosing everything above this. You are not diagnosing below this. If you are using 10th percentile, you are diagnosing.
I think Divya is speaking right. Actually,
So,
the
right side the curve.
right side actually the diagnosing part, na? Right
Okay.
side of the curve.
Right side is so,
Okay.
if we think, suppose we take 1500 as the cutoff for FGR,
Okay.
then that will detect more cases than if we take
Yes.
as 1000, na?
Okay.
So
Right side of the curve is diagnostic.
ideally the
Okay.
dotted
Okay.
one
Right.
should be okay.
Right. You're right. Yes. This dotted ones will pick up more adverse outcomes than this one. This one will, yes. Because everything below this. We have
Below
to-
this?
Correct.
So
You're
we're
right.
missing the red dots above the.
Yes.
If we're taking
So,
the lower one.
so if we are using this dotted ones, yes, if we are using these dotted ones, we are catching more number of red dots, right? Because we have to see below this, right?
Yes.
Okay, thank you. Now there are a lot of growth charts, more than 80 different growth charts. They are broadly classified into either population reference chart, where they use live birth weight or ultrasound based effective fetal weight, standard chart, or the prescriptive terminology which we use for the standard chart, which includes your Hadlock, Intergrowth and WHO. And other is the customized chart, and then there is a debate whether to use a universal chart or the customized chart. Okay, so the consensus is to go for the standard chart, and in that standard chart there is problem with intergrowth also, and there is some problem with WHO also. Now if we discuss separately about this growth chart, we can discuss that in detail. So mostly this Hadlock they found to be very good, and this Hadlock was most of the time when they compared the effective fetal weight and the postnatal weight, that was correlating with the Hadlock chart. Now there are several studies, several papers on that. Okay, you can go through that, or we will discuss in one of our talk also. Now what are the tools? These are the different tools. One is the Doppler, multi-vessel Doppler, where we'll be using umbilical artery, middle cerebral artery, uterine artery, aortic isthmus, ductus venosus, all this we'll be using. Other is your CTG or CCCTG. This is computerized CTG. This is your conventional CTG. Cardiac functional assessment. Then the biophysical profile and amniotic fluid assessment. So, and apart from that, there is one more thing, that is fetal kick, which is very important. So these are the tools which we will be using to 5D which we mentioned. So these tools we can use to detect that. Now, if you look into this slide, this side is the maternal circulation and this is the fetal circulation. Okay, so there is a supply from the uteroplacental circulation, and this supply is to meet demand of the fetoplacental circulation. So this fetoplacental circulation, that demand is met by the uteroplacental circulation. So whenever there is discordance between supply and demand, less supply or more demand, like in twins, we see the growth is little bit less for both because demand is more, supply is restricted, limited supply, or vice versa. If there is placental damage, supply will be less. Demand may be the same, but supply is less. So if there is problem with this supply and demand, then there is very high chance that there will be issues with like growth restriction, fetal growth restriction. Now, something very important I want to discuss here is standardization. Like when we talk about different tools, Doppler tools, it is not just a Doppler tool, it is about the standardization also. Like when we are doing the uterine artery, at the crossover of the iliac vessel, downstream, you have to place your pulse wave Doppler, sample volume, okay? And then you have to take a tracing, and your peak systolic velocity should always be more than 60 centimeter per second. Right? Again, I should show you. First, in the gray scale, you see this vessel which is dropping down. This is your uterine artery. Now, this is your iliac, external iliac vessels. Now, after the crossover, this portion you have to insonate, and you try to get a clean waveform, and from this you first see your peak systolic velocity. It should be more than 60. If it is less than 60, that means you are not into the main uterine artery, you are into artery artery or spiral arteries, whatever.
So we need to change the axis of this one?
Yeah?
Axis, do we need to change the axis of the...
For the peak systolic velocity.
So PI also formulate. For uterine artery, when we are insonating the velocity, do we need to change the axis of the gate?
No. Angle of the gate, because we are looking at the pulsatility index basically. Pulsatility index is a ratio.
Yes.
So angle does not affect. But yes, your envelope, this is your Doppler envelope. Okay, this is your Doppler envelope. This Doppler envelope becomes more clear and crisp if your angle of insonation is close to 0 degree.
So often I've seen, suppose the peak systolic velocity is around 50. If we change the angle, it increases to 60.
Yes,
So
yes, yes, it does that. But then what you do is without correcting or without steering this, you try to get this flow more or less in this alignment. Okay, because I don't want that falsely recreate more than 60. Okay, so you can try that. But the idea is that you should first recognize your uterine artery and then place. And sometimes if you are not getting a very good waveform or struggling, no problem. You try 2 times, 3 times, or go for some other and again come back, because not always things will be very clear. Sometimes you have to struggle to get even uterine artery. But yes, case to case basis, if you start doing it, you will understand that. And then, because standardization is very important, whatever we do, like umbilical artery we are doing, you have to zoom your image, narrow down your the sample volume, and place the because mostly we are doing from the free loops. We are doing from the free loops for the singleton pregnancies, and try to get the waveforms where you will have umbilical artery and umbilical vein. This is umbilical vein. So umbilical vein also you should get below the baseline. That means your filter is correct. If your filter is very high, you will not get the venous flow. You get only arterial flow. And in middle cerebral artery, that angle is very important. You have to be as close to 0 degree and get your waveform, and then based on that you can do auto tracing if baby is or mother is breathing too much, because the biggest hindrance in all this is breathing artifact. So if she is not able to hold her breath, or baby is moving here and there, is difficult sometimes. So in those cases, if your waveforms are not very homogeneous, then you do a manual tracing. For the best waveform, you do a manual tracing. It happens sometimes. Then you cannot just put your auto trace, because auto trace will then average the everything. If you are getting homogeneous, then you put auto trace. Otherwise, you can do a manual trace.
Sir, I have a small question.
Gate size should be here
2 to
5
3 millimeter.
8 or 5.
2 to 3 millimeter generally. This one just I have increased to get
Venous flow.
Venous flow. If it is very tight, sometimes you may not get the venous flow.
Sir,
But generally they say 2 to 3 millimeter. But yes, you can go. Except ductus venosus. For rest of the things you can go 3, 4, 5. That doesn't matter.
Sir, here is my question: that why you have taken the venous flow? Is it important or?
It is important because whenever you are doing this Doppler for growth restriction, umbilical artery, you need to see what is happening in the venous side also.
Okay.
Because in the severe case of growth restriction, there may be problem on the venous side. When it starts decompensating, there is sinusoidal flow on that umbilical venous flow
Okay,
pattern,
okay.
which
So
is
if that
which is an indicator that baby is into acidemia. So always try to get artery above and vein below
Simultaneously.
simultaneously. That should be the standardization. If you are not getting, increase the gate, you will get that. It's very simple. And secondly, it also tells you that your wall motion filter and other things are fine. Like we discussed the optimization, those are fine. So this is again ductus venosus. You zoom it, okay, zoom it properly, and then you place, see the aliasing one. The
Yes.
part which is aliasing is your ductus venosus. Now you place your sample volume there, and then there are some artifacts. These are all contaminations. But you know A wave is well above the baseline. And the same thing if you want to do for the isthmus, so you go for that 3 vessel trachea view, and there you take this.
Sir,
But aortic isthmus, I am not interested in discussing aortic isthmus because it is still research tool, and we are not managing FGR based on the aortic isthmus Doppler. Okay, so the tool which we are not using, we will not discuss that. Now I told you this 30, 50 and 70 rule, okay, and that 30% if there is problem with the placenta, 50% and 70%. High resistance, absent end-diastolic flow to reversed end-diastolic flow. We will go to next. Middle cerebral artery, things which we should know that where to sample, how to sample, and when we see, what is CPR first? Last time you were there, what is CPR?
PI of
PI of?
MCA by PI of uterine umbilical artery.
Okay, so we should be on the numerator and we should be on the denominator.
MCA in the denominator.
Numerator, denominator.
MC is always numerator.
Numerator.
MC should be above and
More than 1. So it's will be more than 1.
pulsatility always should be in the.
So CPR is the ratio where MCA PI by umbilical artery PI. And this is more sensitive than MCA. But it is less specific for fetal hypoxia. That means if you have this CPR abnormality, you can pick up cases. But how to prognosticate based on CPR is difficult alone. If it is late onset, you know CPR may be the only abnormality. But early onset, abnormal CPR is the rule. It will happen because this is a compensation which baby has to do. So based on the abnormality of the CPR, you will not take any decisions of delivery in early onset. CPR will be abnormal in early onset FGR at some stage or the other, because that is natural. It's a early onset. The disease onset is early. Placenta damage, Now the umbilical artery high resistance. What the fetus will do, it will try to redistribute its supply to the vital organs. So fetus is auto-regulating for the hypoxemia. So that is a compensation which fetus is doing already. Okay, based on that I cannot take any decision. Like when they read the report, the obstetrician, they will say, oh, 28 weeks cerebral redistribution, I need to deliver it. No, you don't need to deliver it. It's just a compensation which baby is doing for its survival, right? So there the decision for delivery will not be based on the CPR, it will be based on the venous Doppler, like ductus changes, ductus venosus changes.
But early onset CPR changes will be there. Na?
Will be there, but we will not act on that. We have to ignore that. As long as our
is not that sensitive to pick up the normality, so
Yes.
But that
CPR changes
CPR,
will be
that
there.
CPR will not, that CPR changes will not be there in a very early phase of early onset FGR, na?
it will not
Because
be in the very early,
due
yes.
to less sensitization of the
It will take some time to develop,
But it will develop.
but
It
it
will
will
develop.
develop.
It will
It
develop.
will develop. You will never find early onset FGR without redistribution. It will develop, okay. But we cannot take decisions of delivery. Late onset, yes, that is a separate issue.
Sir, in case of early onset, if CPR less than 1, then we have to check the umbilical artery Doppler, absent, reversal. After that, the venous Doppler.
Nah, I will come back to this.
Okay.
I will come back to this. This is a very valid doubt. I'll come back to this. Okay, we have slides. I'll come back to this. And then also, if it's not clear, I will explain.
Okay.
So this is an early onset. This is just a reflection of compensation. But yes, in late onset, this is a prognostic marker. Because you will not bank on changes on the venous side for late onset FGR management. CPR abnormality, done. Then you have to plan for the delivery. Now this is the formula, right? Why I asked you, because many times still there is a confusion on the numerator and denominator, okay? And by nature, always middle cerebral arteries are high resistance flow vessels and umbilical artery are low resistance flow vessels. This is normal. So if it is high resistance, what will happen to the PI? PI will be higher. So normally ratio more than 1 is always just normal, physiological. And anything less
Sir,
than 1,
why
but
should we take middle cerebral artery? In this image, there are peak systolic velocity at the origin and the independent indices at the on the
So
left
the
side
vessel,
image.
the anatomy of the vessel she is asking.
Acha, anatomy of the vessel. This one, huh?
Yes.
Where we will put the gate.
Acha, see, this is your middle cerebral artery. Okay. So on the distal aspect you have to put, not very proximally, because if you
Not
put
near the
very
origin. This will sit away from the origin.
if you place at the origin very close, then you will get the waveforms of the internal carotid artery also.
Okay.
So you have to place little bit distally.
Okay.
Now there is no measurement like how distal is distal. You have to place it little distal to it. And if you are not satisfied with the waveform, you can move little up and down and see. Okay, then you will get a correct waveforms. Now ductus venosus Doppler. This is the strongest Doppler parameter to predict short-term risk of the fetal death in early onset FGR. Now this is something which is a very short-term change. Like if you see ductus venosus change, then you need to deliver within 48 hours. This is not a chronic phenomenon like CPR that it will persist. Ductus changes happening, that means there is chances of impending intrauterine demise. So they have to act on it because acidemia is already happening there. In 90% of the cases, it is abnormal just 2 to 3 days before abnormal biophysical profile. And why it is before biophysical profile, that I will explain you. Abnormal DB is considered better window of delivery threshold. Okay, that we understand. Now, I told you something about daily fetal movement count also. And this is a very good actually safety net. Now, patients will ask, what should be the count? What should be my count? Somebody will say, okay, 10 counts in a day, 20 counts in a day. It's nothing like that. There is no threshold. Now the problem is every mother is having her own pattern of the kicks from the fetus. So you have to just tell her that you understand your fetal kick best. If you find any deviations from there, then you come back to us for a check, scan. Otherwise it is fine, because I have seen mothers where fetus even they are not kicking or once or twice kick in a day, she's used to that kind of movements. and the other is very rapid, but then she's used to that kind of rapid fetal kicks, and if she's not getting, she's worried about that. So we cannot fix for her 10 counts, 12 counts, 15 counts, nothing like that. Just her pattern of things. Now there are software also you can do that. Other thing is CTG. In this, I will not discuss about the CCTG computerized because we are not using this. The CTG, you people are obstetricians, you are using on a routine basis. You have much more idea than what I have. But there are two things which in CTG generally you are supposed to see. One is your variability and other is your decelerations. So variability can be again subjective. To you it may be variable, to some it may not be that variable. So based on variability again you cannot determine the delivery threshold or you cannot plan delivery. But if it is deceleration, late deceleration, that is pointed towards acidosis, then you have to plan for the delivery. Okay. Now, biophysical profile. These are all the parameters for the biophysical profile. Okay. So, for examination, we used to memorize all this, but when we are scanning, and some of the doctors, they will ask you to do biophysical profile scoring. Even in USA, they are a big advocate of biophysical profile. They don't recommend ductus venosus, but they want biophysical profile. And there are doctors where you will get the prescription where it is written BPP. Now what to do once you get that BPP? You cannot read all this and you cannot do all this. It is not possible. So the concept you have to understand how to deal with this biophysical activity. Now there is something called gradual hypoxia concept. That these are the things, I'll just show you all the four. Now these are the things which appear at this time window, 7 to 9 weeks. This is the time of appearance. Then gross movement 7 to 9 weeks again. Breathing movements 20 weeks, fetal heart activity 28 to 30 weeks. Okay. So this biophysical activity, the appearance of the biophysical activity, now the earlier it appears, the later it will disappear. And the later it appears, earlier it will disappear if there is problem. Okay. This is related to the pH. Less than 7.1 and 7.1, 7.2, 7.2. Now, when there is acidemia or when there is fetus at stress, these four components, the first component to disappear or show abnormality will be this, because this was last to occur, so first to disappear. Then this is, again, fetal breathing movement will go next, and then the tone and gross fetal movement. So there is no point in monitoring these two because they will be last to go. So what we are interested in monitoring is CTG. CTG will look after this, or NST, non-stress test, and then the fetal breathing movement. So NST or the CTG, CTG can monitor for this decelerations and variability, but when we are doing ultrasound, we cannot think of that. So what we can think of is breathing movement. So whenever you are doing Doppler and Dopplers are abnormal and you are expected to provide information on the biophysical, you just look at the fetal breathing movement. If your fetal breathing movement is very easy to see, you go in the coronal section and just see the diaphragmatic movement, it's very easy, or the abdomen bulging, so it's easy. So if breathing movement is sluggish or absent with abnormal Doppler, that means the biophysical profile is abnormal. But you have to spend some time, might be transient, baby is not breathing. Okay, so this will disappear in this order, and then finally it will result in fetal death. Right? So always what we are doing, and I think you people are also doing the same thing, that growth restricted fetus, look at everything, anatomy, Dopplers, everything, and at the end we also see the breathing movement and documented fetal breathing movement was seen throughout the period of examination. It appears normal. That is why a concept came of modified biophysical profile. So modified biophysical profile looked at NST and amniotic fluid. But that is only when you do CTG. An ultrasound, I cannot comment on NST. So on ultrasound, what I will do is modified biophysical profile on ultrasound is looking at the breathing movement and the amniotic fluid. Unfortunately, amniotic fluid is a very chronic variable. So you will see with borderline reduced Liker also maybe surviving, maybe doing well. So we cannot predict based on the amniotic fluid how is this fetus in future, how this fetus will behave. Now, this is the slide which Ankur has discussed, and this is the Delphi consensus, which is Yog and Figo uses, which we have seen in the previous slide. Now, early onset, less than 32 weeks, these are the solitary parameters, and these are the complementary parameters, where you will use AC and effective fetal weight, but apart from that, there is a Doppler, umbilical artery, and uterine artery. Now, how many of this you need to prove it is early onset FGR? There are 1, 2, 3, 4. So out of 4, how many you need?
You need
Two. You need 2. Okay? So these are like major criteria, minor criteria kind of thing. Here even 1 is sufficient, but here you need 2. And this is the solitary parameters, and these are the complementary parameters for the late onset FGR. And this is the quartile I was discussing. So 1 quartile is 25%. So like a baby was growing at say like 75th percentile, and then, which is normal, and then it dropped to 20th percentile, which is again normal, but then there is a drop of 2 quartiles in this. So this thing becomes
So drop of
important.
more than 2 quartiles during any gestational age, irrespective of gestational age.
Between any time, the time interval is not.
Time interval,
Yes.
but generally that criteria Delphi consensus has put for 32 weeks when we are looking at
No,
the
means,
growth velocity.
Between 2 scans, the time interval, the drop of 2 weeks.
Because there is when we talk about interval growth, less than 2 to 3 weeks we should not comment on the growth, because many times it happens they will send every week and then they will give biometry, give Dopplers. So always we discourage that habit and we say, you know, 1 week, every week we will do Doppler, but alternate week we will do biometry, because there will be lot of
Doppler abnormality is that we're calling up, if there is Doppler suppose the FG is less than 10 centile only, then we are calling fortnightly, means after 2 weeks. But if it is just means the growth is going normal, even if we call after 3 weeks, we will see the growth growing down by 2 quartile. 3 weeks is also okay.
yes, 3 weeks is all. Anything above 2 weeks.
Above
Anything
2 weeks.
above 2 weeks. So FGR is basically a functional problem. Like there is a endorsed growth potential for every fetus. Now it is supposed to reach its growth potential, but because of whatever reasons, placental reasons, intrinsic fetal reasons, environmental reasons, maternal reasons, it is not able to reach its endorsed growth potential. That is the basic definition of FGR. But this is a functional definition. How do we understand what was the potential of the baby? So that is in fact the proxy of that is in terms of biometry. When we are serially or longitudinally following up the biometry and seeing changes, then we understand that okay, this was traveling at 50th percentile, but now suddenly it is showing drop to 10th centile or 15th centile. So it was going very well at 40-50. So why it is coming to 10 or 15 centile? And there is definitely some problem in that fetus. And this definition excludes anomalous fetus. So when we talk about this definition at first instance it excludes anomalous fetus. Because animalist fetus with growth restriction is something different. This is completely non-animalist fetus which is showing growth restriction, and these are the I always used to keep this chart in my reporting where we are making the report, just pinned it, because many times you will forget that, or sometimes it will overlap. And similar Delphi consensus is for twins also, DCDA and MCDA, so there is a lot of clutter in the brain. So the easier thing is to pin that in your soft board, and whenever you are typing the report, you can see, okay, this is matching, so should I call, should I not call? So that helps. Okay. And later on, your staff also, she also starts using that. But the biggest problem is late presentation of early onset FGR. Like, it is not dichotomized, like, okay, 32 weeks, it's Lakshman Rekha. Problem is ki when she was scanned and when she is coming to you for the follow-up, in between what happened, we don't know. So unless proved otherwise, you take all those growth restricted cases as an early onset growth restricted case and do everything, all the Dopplers. Like, I suppose I get a case of 32 weeks, 33 weeks, and then I say, oh, CPR is abnormal, now I will deliver because this is late onset. This is late onset. But in fact, it was actually the early onset with baby is compensating and ductus is normal. So we have to be a little bit judicious also. Okay, so do multi-vessel Doppler every visit it comes. Now,
Sir, okay, I will ask later.
Okay, now stages of for FGR. This is 4 stages. Number 1 is mild placental disease or mild placental resistance, where you will see high resistance flow in the umbilical artery and middle cerebral artery will show redistribution. CPR will be abnormal. Uterine also abnormal. So this is the mild placental. Effective fetal weight may be less than 3rd percentile. Then comes the severe placental resistance or severe placental disease, where you will start, where the placenta is more than 50% damaged and you start getting absent end-diastolic flow. And the other is aortic isthmus changes, but aortic isthmus I am not discussing, that's why we will restrict to ourselves to absent end-diastolic flow. This is stage 2. Stage 3 is low suspicion of acidosis, where you get reversal in reversal of flow in umbilical artery, and ductus venosus also starts showing high resistance flow pattern. The PI is more than 90 or 95%. This is high suspicion of acidosis, where DV is definitely abnormal, and also there is CTG decelerations or reduced short-term variability if you are using the CTG. So CTG, I don't know where you have written deceleration. So these are all the stages: stage 1, stage 2, stage 3, stage 4. So if you understand what happens, you can very well say which stage this case belongs to, or else there are now all that calculators, Barcelona calculators, FMF calculators, you put in that, it will give you which stage you are in and recommendation when to recall them. Okay, but forget about those calculators, we should understand the basics, and if you understand the basics, even without the help of AI, you will be able to do it. So this is mild, severe placental disease, but these two are actually in the stage of hypoxemia. Hypoxemia, we don't need to actually deliver this, but yes, once it starts developing acidosis, we need to deliver it. But then when to deliver, that is the, and when to recall them. If you are serially scanning them, if you are not delivering, then what? You have to recall them. You have to call them back. So when you will call them back, that concept we have to understand. So this is the timeline of the different stages of growth restriction. Now this is the criteria, delivery, follow-up, mode, mortality and morbidity. Now stage 4, if you see, stage 4, the criteria is reversal, DV reversal, abnormal CTG. Okay. Now with this you deliver anytime. You deliver anytime. Okay. And follow-up, if you are following these cases, then it has to be done on hourly or daily, which is not possible. Mode, cesarean, mortality, morbidity, 50, 90%.
So do we have time to give the corticosteroid in this case?
Rescue you can give. Now,
What a
reversed and diastolic is the criteria for stage 3. Reversed and diastolic, okay? Low suspicion for
Acidosis.
acidosis. Now, in this case, or if DVPI is more than 95th percentile, delivery is recommended at 30 weeks, and if you are following up, suppose it is not 30 weeks, early it is 27 weeks, 28 weeks, then you have to follow it up every day or every next day, alternate days. Mode of delivery is cesarean, and morbidity, mortality and morbidity is 10%, less than 10%, 50% respectively. So, in the reversed and diastolic flow, the threshold is 30 weeks, but the range which the society gives is 30 to 32 weeks. But generally, at the lower one, it is recommended that you deliver it. I'll show you that also. Stage 2, there was high suspicion, there's severe placental disease where there's absent end diastolic flow. Here delivery at 34 weeks and twice weekly monitoring. You can deliver by either cesarean or labor induction. And stage 1, where there is mild placental resistance or disease, you get abnormalities in all this Doppler, but still 37 weeks you can take it with monitoring, and monitoring has to be done once weekly. Okay, and this is the respective range: 28 to 30 weeks, 30 to 34 weeks, 34 to 37 weeks for the delivery. Now, the problem is when the truffle trial came, truffle trial had some limits, and they said you deliver it out when DV abnormality happens, okay, or CTG abnormality happens. Now, many people started believing, when I was in Mediscan, that time we were also believing the same thing, that okay, I will not deliver this baby whatsoever ways unless my DV is abnormal. But in the truffle trial, they have used safety net. That safety net is the fine print which many people, they read the paper but they don't understand. Whenever they say, whenever you are following this growth restricted babies and you are waiting for the DV changes, in between the scans, you should have a safety net in the form of CTG monitoring. Like suppose I am calling her, once weekly or twice weekly. So in between what happens? In between you have to follow them up with a CTG monitoring.
Daily CTG or?
Daily CTG or alternate day CTG. So you have to blend your scan with the CTG monitoring so that you have a safety net in between. And also, umbilical artery as a standalone criteria for delivery happens only after 30 weeks. Umbilical artery. Why I'm saying, like absent end diastolic, I have a license to deliver at 34 weeks. Reversed end diastolic, I have a license to deliver by 30 weeks. But this decision you can take only after 30 weeks. Before 30 weeks, umbilical artery is used only as a diagnostic marker. You can use it for detection of FGR, but you cannot use it to predict when you will deliver them. Are you getting me? There were two markers which Ankur discussed last time, diagnostic marker and prognostic marker. So umbilical artery before 30 weeks is only used as a diagnostic marker. But after 30 weeks it is used as a prognostic marker. Now if you are getting absent end diastolic flow in umbilical artery at 30-31 weeks, then there is no logic that you will say, no, my umbilical is abnormal, but I will wait for my DV abnormality. Then you will not even insonate DV. You don't want to have a look at a DV because now you have a license that okay, my umbilical is abnormal and this is a threshold for delivery, so I will go ahead and deliver it.
So
I
this
will not wait for the DV abnormality.
standalone criteria is valid after 30 weeks only due to that chance of redistribution is much more early.
Which one?
The standalone criteria after 30 weeks is valid only for that cerebral redistribution chance is much more early after 30 weeks.
After
That's
30.
why.
Now, after 30 weeks, that may be one of the explanation. But after 30 weeks, what happens? See, you have to balance your morbidity and mortality. Okay, you have to balance your morbidity, mortality. Now, absent end diastolic flow means your 50% placenta is damaged and baby is severely hypoxemic. Now, prolonging this will have a morbidity. So, I need to deliver it out.
But before 30 weeks.
Yes, before 30 weeks, umbilical artery cannot be used, CPR cannot be used for the delivery
Here
threshold.
is my question. Means CPR is changed. That means already cerebral redistribution started.
Started.
And then after that, as soon as the cerebral redistribution started, that means brain is mature.
Yeah.
That's why cerebral redistribution started. After
No,
this,
no. Brain maturity is different. See, cerebral redistribution started because baby is trying to auto-regulate. Baby is trying to compensate for the resistance of the umbilical artery. That's why it
that will
started.
be followed by cardiac problems or whatever.
Yes, but before that cardiac problem, DV will be abnormal in early onset.
Okay.
Before that, there will be problem with that cardiac function, and that cardiac function changes will be reflected in the form of DV. And then there will be problem with the CTG.
But in case of late,
In the late, it will be the other way. Cardiac heart is happy because placenta is not that damaged. Umbilical artery is fine. Heart is happy. The problem happens from the brainstem. That is why CTG precedes your Doppler changes in case of late onset, and the other way it happens in early onset. Are you getting me? Now there are two concerns whenever we discuss this. One is the fetal risk, where obstetrician's perspective is important, and the neonatal risk, where the neonatologist perspective is important. So it is a good idea that even you enroll or even you put your neonatal team also into discussion, like if you're planning to deliver, now how are they comfortable to deal with that premature baby? Different NICU have got different way of responding to the same weight of the baby or same gestational age. Some say, okay, you give me anything above 28 weeks, we'll manage. Some will say, no, we are not equipped to manage this. You at least take it 30 weeks plus. So, all these things you have to take into account, because the fetal risk is in the form of hypoxemia, acidemia, finally stillbirth, and neonatal risk will be prematurity and prematurity related morbidity, and in extreme cases death. And now, what does parent wants? Obviously, they want the best of both. The fetal risk also should be minimized and neonatal risk also should be minimized. So here comes the two important players: delivery threshold and monitoring interval. So your delivery threshold, if your delivery threshold is very high, there is chances of stillbirth, and your monitoring interval is very low, then again there is chance of stillbirth. So you have to have an optimum delivery threshold based on the Doppler changes which we have discussed in the previous slides, and then if it is not meeting the criteria for delivery and you plan to continue for some more time, then monitoring interval is very important. How should you go about it? And also medico-legally it is important. Like you are managing an FGR case, now the parents, they have all the informations from the net, and suppose I'll just tell you, suppose this case is in stage 2, okay, so you are supposed to call them twice weekly. By chance you have said, okay, you have just called them casually once weekly, we will see, and there is a demise. Then they will say, no, the guideline says that twice weekly you should have called us, you called us once weekly, that's why this thing happened. So what we now do is, apart from staging and all, we give one paper of that Barcelona calculator, so that everything is documented there, and recommendations and everything come there.